plug syndrome is a rare benign form of the colon obstruction in the neonates that bears no relation to the Meconium ileus. Here the Meconium is normal, not inspissated. The colon this motility allows the Meconium in the left colon and rectum to become firm so that a plug is formed that cannot be passed. The characteristically the newborn pass only some small inspissated Meconium or not at all. The abdomen becomes distended. Vomiting is the late occurrence. Abdominal X-ray may shows dilated bowel loops with few air fluid levels and more colon and rectal gas than the patient with the Hirschsprung disease. The treatment, meconial plug may be dislodged and pass after stimulation of the anus and rectum with the physical examination. Using a contrast enema, the enema is performed using the same techniques as in the diagnosis of the Meconium ileus. So we used the enema. Hirschsprung disease, ganglionic megacolon, is a congenital anomaly characterized by the partial or complete colonic obstruction associated with the absence of intramural ganglion cells in the distal alimentary tract. The aganglionosis may extend proximately to involve the entire colon and indeed the entire alimentary tract, exclusive the stomach. I think it's exclusive the stomach. Any newborn presented with the delayed passage of the meconium for more than 24 hours should be considered as having Hirschsprung disease until proven otherwise. Incidence 1 per 5,000, male to female 4 to 1. There is a familial incidence in the 6% of the cases. The etiology of the Hirschsprung disease is unknown. The disease is due to absence of the ganglion in the submucous and intermuscular plexus. The affected segment of the bowel is spastic and narrow. The normally ganglionic colon proximal to its marked dilatation. So we will see the affected area of the bowel is spastic and narrow, whereas the normal one, proximal to it will be markedly dilated. The clinical features, the problems started with since birth. There is the delayed passage of the meconium. The mother notes that the infant is suffering from the chronic constipation. Defecation occurs every few days or only after insertion of the suppository or doing an enema. A progressive abdominal distension notes, and sometimes chronic intestinal obstruction culminates into the acute obstruction with severe abdominal distension, absolute constipation, and there may be vomiting. The most serious complication in the neonatal period is ischemic enterocolitis. The abdomen distended tensely within a few hours, and child vomits profusely while passing a large amount of the foul-smelling gas and loose stool, which may be bloody. During the attack, the patients develop pyrexia and abdominal distension. The lesion is ischemic necrosis of the mucosa of the bowel above the ganglionic segment, often extending to the small bowel. Least common acute mode of presentation is with intestinal perforation, delayed growth and development. Digital rectal examination reveals a narrow, empty rectum, and when the finger is removed, it is followed by the sudden gush of gases and stool. This is one diagnostic sign we can see after the examination. Investigation: plan abdominal X-ray reveals large bowel obstruction in the first few days of life. The colonic distension with the absence of the air in the rectum and plan abdominal X-ray is suggestive for the disease. Barium enema need to done without preparation, and a small amount of the barium is administered. It's usually shows the narrowed ganglion segment followed by the dilated normal ganglionic bowel. Barium retention in the colon for the 2 to 3 days may be the only suggestive sign of the disease in infancy. In old children, an easy identifiable transition zone is usually apparent. Its diagnostic accuracy is 18%. There is no substitute for the tissue diagnosis. Rectal biopsy. Previously full thickness rectal biopsy are recommended, but nowadays only a small segment of the mucosa and the submucosa is taken by the special forceps. The ganglion cell in the submucosal layer are absent. Various methods of obtaining biopsies now has been described. Suction biopsy instruments are widely used in the young infants, but are hence found the use of the punch biopsy forceps to be preferable for the older children. Rectal manometry. This one reveal failure of the relaxation of the anal sphincters in response to the rectal distension. The treatment: patient present by intestinal obstruction. Initial conservative treatment by nasogastric tube section, IV fluid, and repeated colonic washout with saline. If the obstruction is relieved, prepare the patient for the later elective surgery. If the obstruction is not relieved, perform urgent colostomy. Patients without obstruction require elective surgery, pull-through operation. Surgery is ideally performed at the age of 6 to 9 months. Defining surgery for the Hirschsprung disease entails complete excision of the ganglionic segment of the bowel up to the 4-inch above the funnel, and vein anastomosis of the normal colon to the lower half of the anal canal. Pull-through.